And thank you. Thank you so much, Denise. So Denise and I, we drew the lucky straws, and we're asked to be facilitators for this session, so we're excited. I will introduce myself, and then I will pass it to Denise, and she can introduce herself, and then we'll just talk about some basic rules for the session and then get going. So I am Michelle Johnson, and I am the Chief of Pulmonary Critical Care and Sleep Medicine at the San Francisco VA, and I also am the Associate Chair for DEI for the Department of Medicine, and have been very invested in Disparities work and in this conference for the last, 7 years. And so it's been fantastic, and I'm glad that we're able to do this in a virtual format. Happy to be here, and I will pass it on to my co-facilitator, Denise.
Hi, I'm Denise Caramagno. I use she, her pronouns. I'm the UCSF care advocate, or one of the care advocates. And my role at UCSF is to support people around harassment, discrimination, interpersonal violence, and such. So I'm a therapist, and I'm doing your tech today. Good luck with that. Yeah. I think it's going to be okay.
It will. It'll be fabulous.
And yeah, and me too. I was so excited that we got this session. I think that maybe Andre Lynn decided to, bless us, but I'm super excited about the posters here. So thank you all for being here and for including us.
Absolutely. And so I would just ask that if you are not presenting your poster, that you have yourself on mute. We are recording the session, as all of you know, so that we can share it with everyone who wasn't able to be here. And then the last thing I'll say is the instructions had been for each of the presenters to do 5 minutes. And I know that we may not have as many people in this group as others. And so Denise and I thought that maybe we would just go ahead and have people do their presentation around 5 minutes. And then we would open it up for a few minutes of questions before heading to the next presenter. And then at the very end, because we probably will have some time, we'll just open it up to everyone to ask all of our presenters questions. All right. And so with that, fantastic. And so Denise is going to be managing our e-poster session. And so I would ask that each of the speakers introduce themselves before sharing with us their fantastic work. And so with that, I would welcome Mihir Joshi to talk about this wonderful work that he and his team have done.
Awesome. Thank you so much. Yeah. Hi, everyone. My name is Mihir Joshi. I am one of the current 4th-year medical students here at UCSF, and super excited to be here and share with you all some of the work we've been doing within our Division of Hospital Medicine on identifying language, racial, and ethnic differences in inpatient opioid prescribing. So just as a little bit of background, of course, opioid prescriptions in general have been under a lot of scrutiny in the last decade and plus, given the ongoing opioid epidemic. And as providers, there's certainly a balance to be sought between preventing abuse and possible overdose while also providing adequate analgesia and trying to do this all in an equitable way as best as possible. And there's been some previous work in the settings of emergency medicine and surgery to identify such disparities. But to our knowledge, our investigation is really the first to do a deep dive on potential language, racial, and ethnic disparities in the hospital medicine setting. So for our study, we had a retrospective cohort of all of our patients hospitalized at our UCSF Parnassus Hospital from January 2013 to September 2021. And we looked at the overall opioids on an average daily basis that our patients received in general. And we also looked at 2 specific sub-cohorts. So our most common conditions that were treated, which were pneumonia, sepsis, cellulitis, GI bleeds, pyelonephritis, and UTIs, as well as non-pneumonia respiratory disease, as well as 3 select pain-associated conditions of abdominal pain, acute pain, and then acute back pain and pancreatitis. And we, of course, looked at just the general numbers comparing what our patients were receiving, but we also wanted to do a multivariable regression analysis to do our best as possible to account for as many of the different nuances that account for differences in how we prescribe opioids. So we adjusted for patient factors of age, gender, and insurance. We adjusted for some of the hospitalization factors, including receiving ICU care, comfort care, whether somebody was on a pain service or a palliative care consultation, whether they had opioid medications before coming into the hospital, and which discharge service they were on, as we have both hospitals only teams and teaching teams. And then we also adjusted for comorbidities, a substance abuse history if documented, and then treatment with additional medications like buprenorphine or methadone. So for our overall cohort, we had about 62,000 patients, 60% or so of whom received opioid medications, so a good majority of them. And then looking at the multivariable regression results, our overall LEP patients received significantly less opioids than our non-LEP patients. Our Asian, Latinx, multi-race and ethnicity, and our Native Hawaiian and other Pacific Islander patients received significantly less opioids compared to our white patients. And our Black patients received significantly more opioids compared to our white patients. And I should just take a moment to introduce the caveat here that the racial and ethnic categories that we have over here are, of course, social constructs. These are admissions data that are taken for our patients and self-identified when they come into this hospital. And for the purposes of our investigation, are really just a proxy for understanding racism and implicit bias. And there's certainly a lot more numbers and information available in that table over there as well. In terms of some of the interesting nuances from our sub-cohort analyses, there's a bit more information, but I think some of the most fascinating stuff was that when you look at things from a more granular level, there's actually differences that we were able to see in comparison to our overall cohort. And I will just highlight that our Black patients who were treated for our 3 select pain conditions actually received significantly less opioids than our white patients, whereas for the overall cohort, they received significantly more opioids. So just highlighting some of the nuances from looking at things from a more granular level. And we have a lot more information, tables and figures. So if you have the time and are interested, certainly take a look at the poster and click on that link to see some more of that information. And so in conclusion for us, we certainly saw that there's notable language, racial, and ethnic disparities in terms of how we prescribe opioids on our internal medicine services here at UCSF. And I think for us as an institution, it certainly speaks to a lot more opportunity to explore the etiology of these disparities and really unpack the impact of implicit bias, just recognizing that our patients oftentimes just receive these medications because it's so easy for us to click on a few buttons and prescribe in very different ways and not necessarily have standardized practices. And we have so much more room to think more seriously and thoughtfully about how it is that we prescribe. And of course, there's a lot more further work to be done across institutions to validate these findings in different practice settings and patient populations. And overall, I think we're just scratching the surface on identifying these disparities and have a lot more work to do in terms of actually eradicating them going forward. Thank you all very much.
Thank you very much, Mihir. That was excellent. Questions from Mihir? If you have questions, please go ahead and unmute and speak up.
Suppose I have a question. So you mentioned that these were people, the races that everyone identified as were self-selected by the patients. Do you know if there was any difference in like what race the patients were perceived as versus what they identified as, and if that played a role in the opioids they received or didn't receive?
That is a great question. That's probably actually a great limitation to mention, which is that we really only just have the data on admissions that patients provided and not so much individual data in terms of perceptions themselves. So certainly a lot more nuance and just investigation in terms of what that might ultimately look like.
I have a question also concerning this. Were the patients that were not given, like, for example, in the Latinx, how much of the interpreter services were used in order to determine their pain level? And if that was a factor in not receiving enough pain medication?
Yeah, that's also a great question. So the way we did our regression analyses, we were able to essentially look at the language differences separately, as well as the racial and ethnic grouping separately. In terms of the actual use of or the actual identification of our LEP patients, that was done through whether patients self-identified as not having English as their first language, as well as actually having documented use of an interpreter. So there was some concordance in terms of how we looked at that, and certainly a lot of disparities we saw along lines of language as well for our cohort.
Thank you.
I have a quick question. Sometimes in my experience, if a patient doesn't self-identify their race, ethnicity, a receptionist at the inpatient desk might fill something in. Do you know if that is the policy here or not?
That's another great question. I will say I am not intimately familiar with the hospital's policy itself. I know that there is certainly a group, or we had a group in our cohort that were either unknown or other. So if a patient either did not choose anything or chose other, presumably they would be grouped into that kind of category for our purposes.
I have a follow-up question, sorry. Was this only done at UCSF at Mission Bay, Parnassus, or what was it? Did this include Children's Hospital Oakland and the age group over there? And if, this is children, so who helped or assisted the child in terms of determining the pain? And whether or not they received pain medication?
Yeah, that's another great question. So our group for this purpose was just our adult patients hospitalized at UCSF Parnassus. So it did not actually include any of the children who are typically hospitalized at Mission Bay.
Is there anything that is being studied for the children at Children's Hospital or in the pediatric center?
That's a great question. I personally don't know for sure. So I would have to look into that.
Okay, thank you.
Yeah.
Great. Well, Mahir, thank you so much for this. If any of you have additional questions, maybe you could hold them until the very end, but let's move on to our next presenter. And that would be wonderful. So Zane, I know that you are here and I wonder if you could share with us your wonderful work.
Sounds good. Hi, everyone. I guess we can just get started. Hi, everyone. My name is Zane Shabir, and I'm a second-year student here at UC Berkeley, who had the opportunity over the summer to work with UCSF Benioff Children's Hospital Diversity, Equity, Inclusion, and Anti-Racism Council, researching NRC Health Patient Experience Survey data from fiscal year 2022. To provide some background about our project, we essentially recognize that racism drives significant degrees of health inequities that puts minorities at a greater risk for poor health outcomes. As such, our report aimed to analyze discrepancies in self-reported healthcare patient experiences dependent upon patient race, ethnicity, and language based on NRC survey patient data. To do so, we conducted a two-pronged analysis, the first of which was a quantitative analysis, and the second of which was a qualitative analysis. Beginning here with our quantitative analysis, which is the first chart here on top, in which we took our NRC patient survey scores and on a number of different metrics and aggregated a overall mean score for each of the metrics for all races combined. After which we stratified all of our data based on race and calculated a specific racial mean, comparing that racial mean to the overall mean of all races combined, finding the differences between the means, where either the racial mean was less than the overall mean, described by a red bar, or where the racial mean was higher than the overall mean of all patient data combined, described by a blue bar. Here, I know it's kind of small, but if we analyze the second, third, and fourth categories of Asian, Black, and Latinx respectively, we see that their quantitative analyses are dominated by red bars, where compared to the white, which is the second from the right, is dominated by blue bars, which simply shows that on average, Asian, Black, and Latinx patients had a much more negative self-reported healthcare experience at Benioff Children's Hospital in San Francisco and Oakland when compared with white patients, who largely had a much more positive experience than the average. This told us that there is some degree of quantitative difference in overall observed healthcare experiences. However, we want to provide a story behind this quantitative discrepancy, to which we turn to a qualitative analysis. In terms of doing so, for our qualitative analysis, we look to the courtesy and respect question of the NRC patient experience survey data, where patients were provided the ability to rank their overall courtesy or respect from 0 through 10 and provide comments as to why they gave their score. Essentially, from a total of 5,069 overall comments for all races combined, we extracted 487 negative comments that gave a score of 0 through 5, which is considered a detractor score. We then categorize these comments qualitatively into two main categories. The first of which was the systemic-based category that has to do with hospital-wide things, for example, things like cleanliness, safety, or wait times, and separated these from our interaction-based categories that we were more interested in looking at. From our interaction-based categories, we separated these into 4 further subcategories. The first of which was disrespect, which was largely categorized by patients feeling some notion of judgment, rudeness, or respect from providers and staff. The second of which was demeanor, in which patients experience a lack of friendliness in a children's hospital or a lack of approachability between staff and providers. The second and the third and fourth of which were discrimination and language-based discrimination, respectively, both of which themes are relatively self-explanatory, in which patients and staff felt some degree of discrimination, either due to their race or ethnicity, or due to a language barrier present. Ultimately, analyzing here these 4 charts for our qualitative analysis, we see that we first extracted scores of 0 through 5 for all patients, separated these scores of 0 through 5, and from here, stratified them into the following categories that were systemic, demeanor, discrimination, disrespect, and language-based discrimination. Ultimately, we see that the demeanor category was highlighted in blue here, was one of the largest categories in the interaction-based column, which dominated the interaction-based complaints. However, analyzing the gray category here, which is the systemic-based complaints, we see that for almost all of our minority and patient populations, we see that the systemic-based category largely dominated the majority of these complaints. Ultimately, we made a couple of key conclusions regarding our analysis. The first of which is that BIPOC patients had greater non-systemic negative comments than white patients at UC Benioff Children's Hospital campuses in Oakland and San Francisco. And ultimately, our quantitative and qualitative analysis both suggest. Secondly, our thematic analysis results suggest that targeted education on the appropriate use of interpreter services to help resolve language-based discrimination complaints and education to address systemic racism through things like diversity training, as well as other important informational sessions, is needed to improve the experiences of BIPOC patients across Benioff Children's Hospital campus. Ultimately, our next steps are to conduct these analyses on patient experience data for the rest of UCSF as well, expanding solely from Benioff Children's Hospital to the rest of the UCSF campuses, and collecting more data regarding provider race and ethnicity to compare how provider race and ethnicity and patient race or ethnicity influence the degree of satisfaction interactions from patients' self-reported survey scores. Thank you very much.
Wonderful, Zane. Thank you. Questions?
Oh, Zane, this is really important information. Thank you so much. I'm just looking at the BCH results, your little graph with the red and the green. I just can't see it very well, but it does indicate that even in the white zone, they don't provide, they wouldn't recommend us as much as I would expect it, especially receiving all green in terms of positive scoring, versus Latinx, who would still recommend us regardless of the way they were treated in the results of the answers on the red side, as well as African American and Asians.
Yes.
So what have you determined from this in terms of why the white population would not recommend us as highly as their scores indicate?
Yes, so largely, we can draw a couple of conclusions about this. Obviously, these conclusions are largely speculative just because we didn't really have access to specific comments that patients reported for each of these individual categories for the scores that they gave. But largely, at least, especially for the Latinx category, we see is largely dominated by a lot of red, which means that the overall experience was a lot more negative in the subcategories, except for the would not recommend, where it was more positive. We here see that it might be due to some degree of almost complacency on their part, where they've come to expect significant degrees of negative understanding of care. So they've come to expect such negative experiences that even though their experience was maybe similar to the negative experience, they thus then just say they will still recommend the provider because they expect this negativity to happen in the first place. Whereas possibly for white patients, they may really enjoy or have a significant positive result on many of their metrics, but still feel that they would not recommend that provider for maybe some small, minute reason here or there. Ultimately, these are all like largely speculative conclusions on my part and the part of our team that did the analysis, just because we didn't have access to the comments that patients provided or the reasons why they provided these scores. But our speculation is that there may be some small minutia factors that are involved here that weren't particularly captured by the points in other surveys that led to the would recommend score here. Whereas we feel maybe Latinx patients have come to expect a negative degree of care, and thus they would still recommend providers despite having negative experiences.
I have, as a Latina, I have an opinion of, a thought about that is that regardless of what type of care they get, sometimes they're just very appreciative of any care they get. And so, and that part makes me, I just feel the humility, the humbleness of the culture. But thank you
Exactly.
so much. This is great information. Thank you.
Thank you very much.
Maybe one more question for Zane. Zane, I have a question really quickly. So this was done at Benioff Children's Hospital, and I wonder what proportion of the responses were from parents or caregivers versus from the actual patients themselves who are the children.
Yep. So largely, if I can speak to the qualitative analysis for that, just because again, as I mentioned earlier, we didn't really have access to a lot of the comments that were given for the quantitative analysis arm. But for the qualitative analysis, the large majority, I would say nearly upwards of 90%, I would say at least, were responded by parents and caregivers. So the large majority of survey responses were done by parents and caregivers rather than patients themselves.
Thank you for that. All right. Okay, well, Zane, thank you. And maybe we can go to our next presenter. And our next presenter, drum roll please, is Davy. Wonderful. Yeah.
Hi, everyone. Yeah. Oh, sorry. Please go ahead.
No, I hope I pronounced that correctly, and the floor is yours.
Great. My name is Davy Rand. I'm a medical student at the University of Rochester School of Medicine and Dentistry. I use they, them. I'm fourth year, currently applying to internal medicine. And my presentation is entitled The Ethics of Disclosing One's Identity as a Transgender Medical Student. So for this project, I interviewed a bunch of different transgender students across America to ask about their experiences being openly transgender at their schools and what that had looked like for the purpose of raising awareness and we could help in the recruitment and retention of transgender medical students, given that we know how much diversity is important to patient care and outcomes. So it's a little small on the screen here, but basically I argue that it is an ethical dilemma to come out, even though there's no right or wrong answer. There's still the questions of like, do trans students, and I'm included in this, do we owe disclosure of our identity to people throughout the course of medical school? Do we owe it to our community as representatives that have historically been represented in medicine and have often been taken advantage of by medicine? Do we owe it to our patients who are in a lesser position of power to say that, hey, we are trans and in medicine and we're here for you? Do we owe it to our coworkers? Do we owe it to our institutions? Do we owe it to ourselves to come out? So these are just questions. Again, there isn't a right answer, and everyone has a different answer. For me, I did make the decision to come out for the purpose of having patients and coworkers be able to identify me as a safe source for LGBT health. And to represent my community however I can and to help pull in other people with me. But that's a decision that I had a great privilege to make because it didn't put me in a position where I couldn't live my life, I couldn't go to school safely and things like that. So in this poster specifically, I utilized the scenarios that many different transgender students spoke to me about and came up with kind of the most common hypothetical scenarios that students might experience in each year of medical school. So for the first year of medical school, you're introducing yourself to everyone for the first time. And this is a time when people often make the initial decision if they're going to come out or not. It's difficult to come out and or not come out because you don't know people yet. You don't know how it's going to be received. For a second year, again, you have left and then you come back and people might not remember you. Teachers might not remember you. Do you email before class to let teachers know? Do you tell teachers during class and risk being considered burdensome or interruptive? Do you remind your coworkers in person as well and risk your physical and emotional well-being? I have a statistic here which says that 3 in 5 people will deliberately leader, a trans person, to show disrespect. And one of the things a lot of students talked about was not coming out because it was less hurtful to be misgendered by accident than it was to know that they were being misgendered on purpose. For third year, we do rotations and we change teams. We might change hospitals every week, every couple weeks, every month. Again, we don't have time to really get to know people or to get to know the culture of where we are and to learn how safe it is or how helpful it is to come out. So you have a choice. Do you come out immediately to your entire team, risking like transphobia, risking being pigeonholed as a being forced perhaps to educate others, and that would go into your own educational time? Do you wait to know the team better and then come out partway through, which kind of risks people in your team being disconcerted and offended that you didn't come out in the beginning, or the same issues of being pigeonholed, dealing with transphobia, or because they've already met you using a certain set of pronouns and name, for example, having difficulty switching over? Do you never come out because the rotation is so short and then you get evaluations that might misgender you, which then goes into your MSPE as you apply to residency and move? Or do you not come out verbally, but decide to come out in other ways, such as wearing a rainbow pin, wearing pronoun pins, and waiting for someone to ask? And this, has pros and cons as well, because some people do notice pins and some people don't. And you can never really know if someone is not gendering you correctly, if they are purposefully ignoring the signs that you have, or they just aren't familiar with them. Finally, we have fourth year. So in this example, I talked about a student seeing a patient with an attending, and the patient is possibly transgender and clearly would benefit from someone transgender in the room. In this circumstance where you are not the person who has the highest level of privilege in the room or level of power, do you make the decision to come out to support a patient, or do you not say anything and just offer support to the patient as an ally? Or do you try and see the patient alone outside of your attending? Again, these are questions that people have throughout that really takes up a significant amount of mental burden that other people don't necessarily have to deal with or don't realize that trans students are navigating at all times. So the purpose of making which I have here in my conclusion, is to help people be aware of these questions, help trans students know they're not alone in asking these questions, and also make sure that allies and trans people can help build a community in which people feel comfortable to come out or not come out, however they choose, without worrying about the potential consequences of it. That would be the ideal scenario. So I want to emphasize the scenario as not having a situation where everyone comes out. Many people are very happy closeted, and that is their choice, and it's the way that they work best, and that's completely fine. It's just that they need to have that choice. So ways that allies can support trans students is, first of all, actively acknowledging the presence and power of transgender students and providers, for example, as people who have unique cultural competency, engaging in trans health advocacy, even when no openly transgender people are present, actively educating themselves and others on transgender healthcare, reaching out and offering extra support or continual support to transgender students, and identifying or promoting or empowering transgender voices in medicine. I hear a lot of people say, like, well, we don't have trans people to look to, and absolutely there are, and even more now as we move forward in medicine and progress. The Med Student Pride Alliance is a great resource for this, that was founded just in the last couple of years, that can connect people to many trans providers in medicine who are happy to share their experience and knowledge, and also have allies also wear pronoun pins and rainbow badges and things like that. So I have some additional references here on the side for anyone interested. On the AMA Continuing Medical Education series online, there's an LGBTQ health kit, which I actually wrote, so I can say, at least from my perspective, some helpful tips on how to work with transgender patients and providers and coworkers, and create just a welcoming environments in general. And then I also actually have a book coming up called At Capacity, which is a series of short stories about being a transgender medical student. And I am one of many resources for trans people in medicine. So I hope you will reach out if you want to, and that this was helpful. And thank you so much, everyone, for being here and listening.
Fantastic. Thank you so much. Any questions for David? No questions?
I have a question. Thank you, Davey. Sorry if I missed this, but were you interviewing other medical students at UCSF, or was it? Oh wait, you did say it was from all around the country. What was your recruiting process like for that?
Yeah, that's a great question. So I really thought about how to recruit, and ultimately it ended up being a convenience sample. So not representative necessarily. And I'm actually a student at the University of Rochester. So it wasn't just UCSF, but I do have friends there as well. So the reason I decided to do convenience sampling is because, first of all, we don't have set statistics of how many people are transgender in medicine at all. They aren't even necessarily underrepresented in medicine by most people. So the demographic data is not even being collected. I actually led the initiative in my school to start collecting demographic data on who was applying as openly trans and who got in as openly trans. So in terms of finding students to reach out to, I couldn't think of a safe and sensitive way to do that would be actually very effective. So what I ended up doing, because I'm plugged into, I like work with MSPA, I'm the website manager, and I am plugged into a lot of different LGBT affinity groups at different levels. I just reached out to my friends who I knew would be interested in sharing their voice, and then did a little bit of snowball sampling, being like, hey, if you have people, you know, who you trust, who are open or who want to share their story, like, please have them come to me. All the information will be totally anonymous. So that's the way that I did it. And it took a long time to get what I felt was like a decent sample. I think I used like 20 interviews for the purposes of this, but I hope in the future there would be a way to be more systematic about it. I think it was great to do convenience. I think at this point, when it's a relatively small known group, I felt confident in that I was representing a lot of people's experiences. But yeah, in the future, it'd be great to really have some like statistics and a real methodology for finding participants.
Davey,
question,
I
thank you.
just have a question on that, or a statement rather. My son is gay, and he was able to, at Kaiser, find a gay physician that he felt comfortable talking to. He had not felt comfortable with physicians that didn't understand the issues the gay men go through, or didn't feel like they understood. Not that I don't know if they did, but he didn't feel like they did. I don't know the process he went through in finding someone that that was like him, who could understand him. So I don't know if they have a process at Kaiser that where they identify gay physicians or LGBTQ plus physicians or not. And I wonder if that would be something that all hospitals should be able to do. You know, especially that makes it easier. You don't have to sift through so much to get there.
Yeah, I absolutely agree. I mean, it's an incredible resource to have. For me specifically, I was looking at medical students. So they aren't people who have their information published like on a school website, for example. But in terms of physicians, I do find that there are many physicians who identify as openly trans, maybe on their private websites or in affiliation with their institution. And there are actually a lot of apps being developed as well that queer people can utilize to find doctors. And a lot of institutions have out and ally lists. So not exactly the those lists are not necessarily queer, but they're people who have said, hey, I want to identify myself as a safe space for LGBT people, whether that's students or patients, and know that they can come to me. And I do think most universities have out and ally lists at this point, but that said, many of them are not updated. And because there is actually no official training in transgender health specifically, the variety of what people know and the experience they have is huge. So again, I'm totally a fan of standardization, and I would love for there to be like a regular educational element, even a certification process, and then you could get on a special website or app or whatever to identify physicians who want to see patients, and even a safe space for students to be able to identify so that they can find each other would be amazing as well.
Thank you.
David, thank you so much for this exceptional work. And so maybe we can turn towards our fourth and final presenter. And that would be Julia. Great. And so Julia, please share your exciting work.
Hi, thank you. Yes, my name is Julia Burns. I use she, her pronouns, and I'm the communication specialist at the UCSF Osher Center for Integrative Health. This research I did while I was finishing up my master's degree this spring in health communication at University of San Francisco. And my research is titled Improving the Experiences of OBGYN Visits for Transgender and Non-Binary Patients Through Communications Practices. So yes, my background is in communications. So I really was looking at this of how can we improve this just through simple communication practices. What really drove me to do this study was I read a statistic that a 2021 study said that 76% of OBGYN residents felt unprepared to treat transgender and non-binary patients, which is a scary amount of incoming physicians. And we already know that this group is at higher risk of negative health outcomes, and a lot of transgender and non-binary people avoid going to the doctor out of fear of, negative health experiences. So again, even just calling the field women's health can be very deterring to trans and non-binary people who don't identify as women but still require this care. So my study asked two research questions. How do interpersonal communications practices impact the experiences of trans and non-binary patients seeking OBGYN care? And also, how do language and images used in signage and intake materials impact these experiences? So I did a qualitative study. I spoke with 11 patients, and the requirements were that they were over 18 in the US, had seen a gynecologist in the last 18 months. And I used snowball sampling. I put out a flyer on my personal social media accounts, and I was thrilled with how far it went. It went all over the US. I talked to people from liberal cities, liberal states, but also from pretty red states and some rural areas, which gave me a really good data pool to pull from. I really want to spend the most of my time talking about the findings and the recommendations I made. I think that's what made this study so valuable, is because it's actionable. So a lot of the things I heard were that gynecologists should avoid assumptions about gender and sexuality when discussing a patient's sexual health. A lot of people said that just how they present physically, their providers would either assume the genders that they were having sex with, which missed a lot of critical health information. So patients really preferred to have awkward, uncomfortable conversations with their providers rather than have that glossed over and maybe assumed and miss that important health information. Another thing from the interpersonal standpoint was to create an open dialogue. Again, just being willing to talk with your patient and saying, acknowledging the patient's needs and if there's anything they can do to make them feel more comfortable. Using a trauma-informed approach for care. We know pelvic exams are already, for anyone, really uncomfortable and invasive procedures. So using a trauma-informed approach, which incorporates clear communication about the tools being used, what touch is going to feel like, and also making sure that the patient knows that the exam can stop at any time. One of my participants said that knowing that the exam could stop was actually life-changing. And then also just interactions around the clinic, making sure that the front desk knows what's going on, eliminate opportunities or instances of misgendering. So just tactfully let other people in the clinic know that pronouns, preferred name, etc. And so that was more the interpersonal communication, and just for the language, signage, and environmental cues. One of the most important things is renaming the field of women's health. One of my participants said, when cis men go to get a prostate exam, it's not called a men's wellness check. It's called a prostate exam. Why are we calling it a women's wellness exam? We can just call it a pelvic exam or a pap smear. So using more scientific terminology to describe the field and the procedures. So calling it gynecology and obstetrics rather than women's health. I don't think there's any harm in doing that. We all sort of know what it is. So let's just use those terminologies. And then also for intake forms, this is what's really actionable and can be incorporated in any clinic, not just OBGYN clinics, but making sure that there's a space on intake form for preferred names and pronouns and sexual orientation. That last one is more important for OBGYN visits, but I also had a participant say in terms of preferred name is, I want that one. I want that for anyone whose name is Michael, but wants to go by Mike, just like having people feel comfortable being called what they prefer to be called in a medical setting. And including more boxes on the form for descriptions rather than, comment boxes, not boxes that you need to check, to allow more options for describing identity and sexuality and hormone interventions. Also, one thing I heard a lot was there's a lot of discrepancies between online experience and in person. So a lot of our online portals provide spaces for pronouns and preferred names, but that's not translated to the clinic. So just making sure that those, the in-person experience is matching what we attempt to do online. And then this is something that Davey mentioned was just like signals of inclusivity. So one of my participants said that, having their doctor wearing a rainbow pin was huge in making them feel comfortable, and it was like a breath of relief, knowing that their doctor was, there to make them feel comfortable. And so I'm not suggesting a full rebrand of all marketing materials or signs in the clinic, but just having a poster or pins on staff that say that this is an inclusive space go a really, really long way. So yeah, those are my results from an interpersonal and more like environmental cue standpoint. I'm also happy to provide more actionable items for transforming intake forms. I think that's something that's really easy that can be done across clinics. And yeah, I'm excited to hear what questions you have for me.
Julia, thank you so much. That was fantastic. Questions for Julia?
Yeah, I have a question. Incredible presentation and wonderful recommendations. I'm curious, as I've heard kind of different things in different communities about the use of like preferred name versus just like name and legal name. If that came up in any of your interviews on the use of that, and also if you talked about the classic like men, women, or both question, that's in terms of sexual activity, and what your thoughts are on that as well.
Yeah. So it came up, we did talk about preferred name a lot, but I guess, we can just say legal name because that's a big problem with, insurance. Insurance is, has to have legal name, and that's what happens on a lot of the forms. But yeah, I agree. It should probably be legal name and then just name. In terms of, men, women, or both, that's what I mean by more of the comment boxes to be more descriptive on the forms at least, and then being able to have that conversation with your doctor of, what sexual partners look like, and what genitalia. It's like whatever's important for your doctor to know, and not have your doctor shy away from that. Like that is at the end of the day, like important information for them to have to give you proper healthcare. So yeah, again, the doctor shouldn't be making assumptions based on what you look like about what sort of sexual activity or activities you engage in.
Yeah, thank you. I want to emphasize just for my clarity, because for men, women, or both, something I've seen in a lot of OB-GYN practices, which will have patients who identify as non-binary and then essentially like forget the non-binary people exist by asking that question. So yeah, thank you so much. The language is great, and I'm really hopeful for these recommendations.
Thank you.
Other questions for Julia? Julie, I do wonder, do you have plans to publish this as a manuscript? Because I would love to be able to send out to colleagues and others like your recommendations. I mean, if they're actionable, which is fantastic, because so much of the work we do, we have theories or, you can do this, etc. But these are very concrete things that people can implement into their practices, and it would just be lovely to like shoot them off of paper and say, hey, look, implement these things. It's really straightforward. So no pressure, but I would just love that.
No, I do have plans to publish this. I'm actually working with a former professor right now on that. So yes, I will keep you posted, hopefully once that's accepted and published.
Please do.
Yeah, and in the meantime, I didn't put my email on here, but I'll drop it in the chat in case people want to reach out to get more advice on, how to transform intake forms and stuff like that. But the goal is to have this implemented more as trainings for incoming residents. And one really encouraging thing I found in my research is that UCSF is one of 2 academic health institutions that has very comprehensive transgender and queer identity trainings for incoming residents. A lot of places don't have any training, and if they do have training, it's maybe an hour. So it's great to see that UCSF is leading in that regard. So it feels nice to be part of an institution where I can actually take these recommendations to our folks to have them implemented, and then hopefully trickle down effect of, people are looking to us as the standard, and so hopefully we'll get this implemented here so it can continue to do good all over.
Wonderful. All right, well, maybe I can take this opportunity to open it up to all of our amazing speakers for questions from the audience. And so if you have a question, please unmute and ask away.
I have a quick question. Davy, where would I find your book?
So right now I'm in discussion with several publishing houses, but if you search my name and medical humanities, you actually, I think if you just search my name, you can find I have 3 stories that already have been pre-published. One of them is in academic medicine called The Mother House. One is in the Family Medicine Education Consortium booklet that just came out this year, and several more actually upcoming. And on Twitter, my Twitter is Davy Estere, and I post updates about my work. So fingers crossed the full thing will get published in the upcoming year, but I already have a bunch of pieces published and more coming in the meantime that are being sent out separately. Thank you so much for asking.
Thank you.
Any other questions?
I have a question for Zane. This was an internship, so what does the future hold for you now?
I mean, a lot of what I was doing with this was this project here in of itself. I'm continuing sort of to talk and collaborate with Henry, who was the program manager for the Diversity, Equity, Inclusion, and Anti-Racism Council at Benioff Children's Hospital, UCSF. And I say you said Benioff Children's Hospital. We're going to continue any work with him and providing any sort of support that he needs and continuing this kind of analysis, extending it beyond Benioff Children's Hospital to the rest of UCSF, and from there as well, providing any kind of support he needs in just, I guess one could say, developing upon the further points of analysis we wanted to do for Benioff Children's Hospital itself.
Great work. Thank you.
Thank you very much.
And we hear this question similar to what I asked for Julia. Do you have plans to publish the data that you had from this poster? Because I find it just really fascinating that overall you felt that the black patients actually got more opioids. But if you look at the conditions in which they were focused on, like pancreatitis, I believe is one of the lower back pain. I mean, these are like really very sort of distinct pain syndromes. And so I just found that to be really interesting and hoping to learn more about your work and your thoughts about this.
Yeah, certainly. We're in the process of putting together our manuscript right now. So definitely looking forward to having that out in the world, hopefully in due time. And then our work actually builds upon our last author over there, Dr. Ramachan, he has also previously published on discharge opioid prescriptions from hospital medicine. And so we're kind of just adding to what is already kind of a rolling ball of identifying these disparities in different kind of spaces within hospital medicine.
All right. Well, we are almost at the hour, and unless there are any last minute burning queries, I just wanted to thank all of our presenters for really the exceptional work that they brought to us. This has been really fantastic, and I've learned a ton. And so I appreciate all of the work that you put into each of these projects, and I wish you much success in these areas moving forward. And also to thank all of the people who attended this session. As Denise and I said in the beginning, we thought it was the best one, and we're so happy that you were able to join us. And look forward to learning more about the work that everybody involved in this health disparities research world is doing. And so thanks to everyone. This session has been recorded and hopefully will be made available to anyone who wants to review this going forward. And yeah, and so thank you very much. All right, goodbye, everyone. Thank you. These were fantastic.